Good morning, everyone. Welcome to today's program, part of the highly acclaimed series of webinars that the Association of Contingency Planners presents for both current and future members. If you'd like more information about ACP, visit them online at acp-international.com. My name is Michelle Lowther, and I'm Principal of Continuity Housing, where we are proud to sponsor the ACP webinar series. At Continuity Housing, we guarantee pre-negotiated hotel rooms at substantial savings for critical employees of larger and mid-sized companies in order to help prevent a business disruption in the event of a crisis. We've created a patent-pending guaranteed employee housing program, which secures and protects hotel rooms for critical personnel, as well as their families if needed, while saving companies significant expense. I'm proud to share that Continuity Housing has a 100% success record with our client deployments, and that each member of our team has a minimum 10 years of hotel industry experience. If you'd like more information on receiving a 30-minute consultation about your deployment housing needs, visit us online at continuityhousing.com, or you can leave a comment in the survey that will pop up at the end of the webinar today. This and previous webinars are recorded and made available on the ACP website and on Continuity Housing's YouTube channel. After today's webinar, you're going to receive a link to the recording via email, along with a copy of the slide deck. Please feel free to share that, the link and the deck both, with your peers and anyone else you think might benefit. Today's presentation is actually a follow-up to a popular presentation that we held in February when we addressed protecting your workforce during a public health emergency through a partnership with local public health. You can view that session in the members section of the ACP website or again on the Continuity Housing YouTube channel. That session discussed the benefits of becoming a closed point of dispensing, also known as a closed pod, by partnering with your local health department, and it provided details of this national program. Today's session will expand on that by reviewing the highlights of the closed pod program and examining case studies from successful implementations of the program. Today's session will include a short review of the closed pod program for anybody who wasn't able to attend, the last one, how employers can benefit from this free program, and then some specifics around how communities in Texas, Missouri, New York, and California have successfully implemented the program. Our speaker today is Harlan Dolgin. Harlan has been a business continuity professional for more than 15 years, having received his CBCP in 2003, and he's a co-owner of Bioterrorism Network, a public health consultancy that specializes in all aspects of closed pod planning, including recruiting businesses and other organizations to become closed pods. He is also co-founder of pandemicprep.org, a 501c3 not-for-profit organization that provides free educational sessions on pandemic and bioterrorism preparedness in the St. Louis area. Harlan has been a BC consultant since 2009 and previously has worked for Thomson Reuters, WellPoint, and U.S. Bank in business continuity and disaster recovery management positions. One quick note for everyone before we start. If you have joined us this morning with specific questions in mind, we invite you to submit those at this time and actually throughout the presentation by using the questions portion of your webinar control panel. Harlan is going to stop once about 10 minutes or so into the presentation and then again at the end to address questions. And with that, please join me in welcoming Harlan Dolgin.
Thank you, Michelle. I appreciate being here today and look forward to this discussion and conversation about closed points of dispensing. So the first thing we're going to do is we're going to talk a little bit about public health in general and what a public health emergency is. There are three things that this program is specifically designed to help prevent, although it may be useful in other types of things. In other types of incidents that involve public health, but primarily we're talking about the three things that are in red. If there was an anthrax release or tularemia or plague. And it may be helpful with smallpox, but smallpox needs more medical intervention. So some places maybe yes, some places maybe no, depending on the medical expertise at the facility. Pandemic diseases, it's not really necessarily good for up front, although there may be some benefits, but primarily because there's not enough vaccination to open up a closed pod and to distribute to everybody that a closed pod would want to service, because the vaccine rolls out of off of the assembly line very slowly. And Ebola, because Ebola wouldn't necessarily be a good effective method for a closed pod, because that's the type of situation where although it can be contagious, but it's not going to spread very quickly, and there's not necessarily enough medicine for a closed pod to be effectively able to address all of its members. And also, you wouldn't want to open a closed pod unless you did have enough vaccine or enough medicine for everybody. So we know for anthrax, tularemia, and plague, we can do that. There are millions of courses of medicine that are stockpiled at different places around the country, and we will talk about that next. First of all, I wanted to talk about what the incidents. And by the way, this is a little bit of a recursor. I took about 26 slides and condensed it down to about 12 or 13 slides in case people did not attend the first session in February. So I assume some people on this call attended, but I'm sure some people on this call did not attend. So we're doing a quick review. So there have been a couple different anthrax incidents. In fact, some of you, I'm sure, remember in the last month or two that there was an unintended release of some live anthrax, and we'll talk about that in a second. But here we actually have, in 1979 in Russia, there was a leak of weaponized anthrax spores in a community, and you can see on the green photo, you can see where the anthrax spread. It spread downwind, so it was carried by the wind, and about 68 people died because of that. Also, you may remember right after 9/11, there was some anthrax that was spread to different political offices. People in the postal facilities got sick, some people in offices got sick, and a few died. So it does happen. We don't want to overblow it, but we don't want to say that it's not possible. So it's interesting enough. I had looked for I was doing a search, and I realized I was searching for information about last month's release, which most of you probably heard about, and found this statement from over a year ago that said that there were some anthrax exposures and that 75 people were being monitored. So this is the type of thing. It's in laboratories. It's one of the big concerns of the federal government, that there might be a release of anthrax, whether we do it to ourselves, unfortunately, or whether someone does it to us. But it's just something we all need to be prepared for. So what we're talking about, this is a public health emergency preparedness initiative. There is actually public health emergency preparedness is a grant from the federal government. Some people refer to it as FEP, P-H-E-P. And literally every county and some cities across the entire country have departments that receive FEP grants or PHEP grants, and they actually have a department called Public Health Emergency Preparedness, and the recommendation from the CDC is to be able to that this department is responsible for is to be able to dispense medicines within 48 hours. They're called countermeasures. In fact, the whole term is medical countermeasures, or MCM, within 48 hours to 100% of the community by the local health department. And the health department, they'll tell you that they have a plan, but they don't have a working plan to get all the volunteers and staff that they would need. I shouldn't say they. I don't want to generalize it. Most health departments don't have enough staff or volunteers to implement the plan. They have a written plan. They're required to have a written plan by the CDC. It's implementing that plan to present to 100% of the community that is the problem. And that's where you all can come in. So what the CDC and what local health departments are looking for is to partner with organizations, I assume like the ones represented on this call, to receive a certain amount of medications. These are free medications. This whole program is free. You would get it from the health department, and you would dispense it to your employees. You can dispense it to your contractors. You also are including your families, and that's very important, because if the families are not included, then certainly that could be could pose a problem because the employer, if they're worried about their family, they're not going to be at work, present, and working for you. So it's a way to distribute medicine to all of your people. This is only pills. It's antibiotics. It's doxycycline and ciprofloxacin, which are two pretty common antibiotics. And this whole program, I had mentioned to you stockpiles around the country. The overarching program is called the Strategic National Stockpile. That's what they refer to it at the federal level. As I had said, they call it medical countermeasures at the local level, and you all would call it your closed pod plan. Some people call it private medication center, but in any event, private, sometimes closed, sometimes workplace point of dispensing or workplace pod is what's used. So there's different terms to describe it at the local level. But at the national level, it's the Strategic National Stockpile. It's operated by the Center for Disease Control and Prevention, or the CDC. They have 12-hour push packs, and if you look at the bottom right photograph, that's one stockpile. We're not allowed to know where the stockpiles are so that the terrorists don't find out where the stockpiles are and trying to sabotage that. They're pretty closely guarded secrets. But there's 12 of them, at least 12 of them around the entire country, and they guarantee that within 12 hours they can get what's called a push pack, which is 500,000 courses to any location anywhere in the country. And that would be very quickly followed by additional warehouses or stores or what they call SNS assets. That would go, so there would be millions of courses that would go to any area if it's needed. Okay, so now we're going to talk about what is a pod, and a pod is not a pea pod, as we have pictured there, but we're talking about a point of dispensing. So there, it's a way of distributing life-saving medication in the event of a declared emergency, and it's a very specific type of emergency that we talked about. It deals with anthrax, tularemia, and the plague. And the plague is the medieval plague that we think about from medieval times, and that is still around in laboratories somewhere and has the potential to be stolen or to be leaked out, so we have to prepare for that. It's organized at the local level, so that's one thing that I would emphasize. In some instances, and I'll get to this later, it could be done at the state level, but it's not something that the CDC can take a Walgreens and say, you're covered in every state. Walgreens employees are covered in every state, everywhere. It's the type of thing where there still has to be some local connection. The pods use staff and volunteers to run the site. There's something called an open pod and a closed pod. So closed pods is what you all would be signing up for. Open pods is for the general public. So no one can be turned down at an open pod. Anybody that shows up in an open pod is going to get medicine. At a closed pod, it is closed off and can be limited to whomever you want to target to receive medications. Okay, here we have a picture of open pods. The medicine goes to the middle, to the pods from the health department, and then your company has to send all your people. The other way to do it is to, and you can see there's longer lines here as well. So the other way to do it is for the medication to make an end around to your company so your company can stay open longer. There's fewer pods needed, there's less lines at pods, and there's shorter lines at your company as well, because you can control how quickly you move people through your lines. So the benefits of participation, life-saving medication when you need it most. There's no cost at all. Even the medication is given out to everyone free of charge. It's part of a federal grant, so the medicine is already paid for. You protect your most important assets, which is your workforce, contractors, and other groups, as well as their families, which is important. You remain open during emergencies. It's a benefit to employees. It gives them peace of mind that you're thinking about their needs and especially their families. And it's part of, you can incorporate it into your business continuity or continuity of operations plan. And so how much does this cost? I'll just go through this quickly. No cost at all. What's my liability? That's a question a lot of people ask. There is no liability due to something called the PrEP Act. You can search for it, PrEP Act of 2005. It stands for Public Readiness and Emergency Preparedness Act. That's where the PrEP comes from. And that is a blanket liability shield, and the only exception to that is willful misconduct. So if somebody's doing something intentionally to harm someone, that would not be covered, which I think you would all understand why. Okay, and now we're going to pause here for questions and see if anybody has any questions on the program piece before we get to the case studies.
Thanks, Harlan. We do have a couple, actually. The first one, and just a reminder, if anybody does have questions, use that control panel, and there's a questions portion there. You can just type it directly in, and it comes right to us. Okay, the first one is, and this is, well, I think this is with the PrEP Act of 2005. How is it legal for someone without any medical training to be handing out, medications?
Yeah, so that does have to do with the PrEP Act. There are different states with different rules in that regard, so you have to follow what your state says. Some states, like New York, Texas, California, the three largest ones, say that if there's a declared disaster, anybody with just-in-time training, 10, 15 minutes of just-in-time training, is qualified then to distribute medicine because they've gotten specific training on what to do. It's only 2 antibiotics. They're only handing out pills. This doesn't include injections. In fact, on the questions slide that I have up, at the bottom, you can see syringes and you can see X's through that, meaning that's not part of this program as a general rule. And so that's why I said with smallpox that needs an injection, those facilities that have additional medical training might be able to give out the smallpox vaccine, but it's not generally for all closed pods. They'd have to be evaluated case by case. And so some states say, no, even during a disaster, we're still going to hold to people have to be licensed in order to dispense medicine. But that would cover a lot of organizations. Some industrial organizations still have licensed people on staff. Universities a lot of times have a health clinic, so they could do it. School districts certainly have nurses, they could do it. So there's a lot of businesses and organizations that still could give out medicine even if the state is very stringent. But there's only a couple of states like that. I know Utah was like that, although I've heard maybe they've gotten less stringent. I think Florida is either there or has policies close to that. We're not in all the 50 states, so I can't speak for all the 50 states. So you just have to find out what the rules were in your state.
Okay. We've received a few follow-up questions to that. First from Cheryl, does a medical doctor need to be on site? I'm going to embellish this, Cheryl. I hope this is okay. Does a medical doctor need to be on site in order for others to dispense?
And that's it's a great question, and sometimes yes and sometimes no. So that's a question of medical oversight. So sometimes there's a requirement that there has to be medical oversight, but the dispenser can be anyone. The dispenser can be anyone who's received just-in-time training. Sometimes, and so again, that's a state-by-state question. There's no one answer to that. So some states do not require that, and I'm not going to list specific names of the states because I don't want to get it wrong. But some states do require a doctor or a licensed person to be present, and some states do not. So you'd have to check with public health.
Okay, public health in your state.
Public health, yeah, in your county would know the answer to that. And if they don't know the answer to that, they need to find out the answer.
Okay, very good. From Stephen, how much medicine is dispensed to an individual? Is it 1 pill or the total number needed to be taken?
Good question. So if it's anthrax, and we're all kind of planning on it, assuming it's anthrax. In fact, the 48-hour requirement is because anthrax, of the tularemia plague and anthrax has the shortest incubation period, which is about 48 hours. So that's why we want everyone to start taking pills within 48 hours. So And I got sidetracked. Michelle, can you repeat the question? Sorry.
Of course, that happens to me too. It says how much medicine is dispensed to an individual, one pill or the total number needed to be taken.
Right. Sorry about that. So, so with these pill bottles, there are 20 pills in each pill bottle. So every member of the family, every person covered under this, will get 20 pills. They are taken. It's 10 days worth of pills because they're taken every 12 hours. And one interesting thing about anthrax is that if someone really has been exposed to anthrax, it's a 60-day course of treatment. So what they would do in this instance is they want to get everybody in the community 10 days worth of medication while they sit back and figure out over the next few days who was really exposed, because there's no harm in taking this simple antibiotic, but there's a lot of harm potentially in being exposed and not taking it. So they want to blanket the entire community and get everybody medicine while they sit and figure out who was really exposed, what area of the community was really exposed, and those people will take an additional 50 courses, and they'll have to get instructions over that 10 days of where to go to pick up the rest of the medicine. Good question.
Okay, good. Bernadette, this one is yours. Actually, I think I just see another one from you. So this is your first question. Regarding the PrEP Act, is there any disclosure that needs to be provided on site regarding allergies, et cetera?
There is, I wouldn't say it's a disclosure, but there is a drug interaction sheet or a drug information sheet that is provided to everyone. So if a family gets Cipro, they would get a Cipro sheet. If they got Doxy, they would get a Doxy sheet. If some members of the family got both, they would get both. And those would have counterindications and other things. So one of the questions on the form, everybody fills out a form before they would get the medicine. And by the way, only one person has to come to your facility, so it'd be your contractor or whomever. They can pick up for the whole family. Well, I shouldn't say that. Generally speaking, that is true. Your public health department will tell you if it's not, but I haven't seen anybody that didn't use the head of household model. So one person's going to come in and pick up for the entire family, and they'll get all the sheets. They'll get a sheet on if it's anthrax or tularemia. They'll get a sheet on that agent that's updated by the CDC and made current as of that particular emergency. And they'll also get a sheet on the drugs that are involved.
Very good. This one is from Bernadette as well, and it's a good follow-up, I think, to what you just said. What about children, or anyone, I guess, children that aren't able or willing to take pills?
Well, there are crushing instructions for children, and different states have different requirements. So some say under 90 pounds, some say under 75 pounds, and under age 8, those types of things. So each state has their own requirements for how to give to children, but there are crushing instructions that I've seen that would go with that. If somebody said they had a child that met the criteria of that state, then they would get those crushing instructions.
Great. Okay, I've got one more here that is program related. I'm trying to sift through these, so I'm sorry, it's taking me a minute. This one's from Adriana. I hope I pronounced that right, Adriana. To be a closed pod, do you need to have a minimum number of employees?
And you do, but that varies county by county or city by city. So I can't really address that. That is one of the things. I think that might be. There's a few different things, and if I don't cover them in the next section, then I'll make sure I try and address them. So some places, Dallas County, it used to be 1,000 employees or more, but they've reduced that to 250 employees or more as we've gone along in the project. So in some places it's 100 employees or more. It really depends on each community and the goals they've set.
Okay, that really seems to be the recurring theme, right? Check with public health in your own area.
It is for some specific, for some specific rules on how they process this program. It really is going to be important to check with public health.
Wonderful. Okay, I only have one more that I think is related to the program. Actually, you know what? I think I'll save this one for case studies. I think we're good. If you guys have more questions, though, please do keep them coming. These are great questions, and it gives everybody benefits from these. So thank you for that. Harlan, back to you.
And it's my understanding that any question that doesn't get answered on the phone, I'll get a chance to provide a written answer to that. So keep the questions coming.
Yes.
Yeah, we did that after the February presentation. So, okay. Okay, so we're going to do community case studies, and I picked out 3. We're going to talk about Dallas County, St. Louis County, and Oswego County. And first of all, Dallas County, where I've been working the longest. I'm at the end of my 3rd year working for them. It's the largest community, or one of the largest communities in the country. Over 500,000 residents have been covered, and the types of businesses, we generally don't specify names of actual businesses without their permission. So I can tell you that large businesses, and actually that 1,000 employees or more should have been updated to 250 employees or more. And then schools and universities are covered. Landlords are covered. That's something unique to Dallas, where there were some leasing agencies that ran some very large businesses in downtown Dallas that said, yes, we want to be closed pods and we want to provide that as a tenant benefit. And so there's 2 businesses, or 2 office buildings in downtown Dallas that are covered as closed pods. Government agencies, grocery chains is another one that is covered in Dallas. And we'll talk more about specific grocery chain in a little bit. And so those are the types of entities that are involved in Dallas. And the large businesses run the gamut from the aerospace industry to some other technology firms. So St. Louis County then, with a population of 1 million, they're the 40th largest county in the United States. And they were our first project, and over 720,000 residents are now covered, which is 72% of the population. We say that St. Louis County is the most prepared county in the country to deal with the bioterrorism event, because we haven't heard any community that has a larger population covered. And again, they covered businesses, schools and universities, government agencies, membership organizations. So the Realtors Association in St. Louis County decided that they wanted to provide this as a benefit to all of their realtor agents in all of their offices and office workers. And so that's something that they were able to do for the entire area. It turned out they have about 8,000 people connected to the real estate organizations. And then grocery chains, a couple of the grocery chains. So in St. Louis County, we actually have 15 of the 19 largest employers are part of this closed pod network there. And then Oswego County, with a population of 122,000, and you know, this shows the 3 organizations that we picked shows that one of the largest one of the largest communities in the country, a medium community, and a small community all had different levels of success, but were successful in creating closed pod networks. So they're near Syracuse. They have over 22,000 residents that are now covered by a closed pod network. For them, smaller businesses, so this got to the employee size, over 100 employees was their minimum cutoff. And one thing I will say is that even if they have a minimum cutoff, if you ask them, and if you're a critical part of the critical infrastructure, you can certainly be considered to be a closed pod even if you don't meet the minimum requirements. So like for utilities, for long-term care facilities or nursing homes, they want to get them covered regardless of their size. So you may ask if you can be accepted from any sizing requirements that they have. Because it was a smaller community, churches was a good place to go to. Schools and universities, if they exist in smaller communities, that's good. And as I said, utilities or critical infrastructure, certainly they want to be involved. In Oswego, they have 2 nuclear facilities, and both of them are involved as well. So, because they certainly want to make sure that they are operational no matter what. Okay. Now we're going to talk about specific companies, and again, I'm not going to name the companies, but I will discuss how they were successful in doing what they did. So the first one is a company in St. Louis that had tremendous management support. They signed an MOU, they provided contact information, which in St. Louis was the requirement to join the closed pod network. And they had a business continuity work group already, so they were able just to incorporate this as just one more arrow in the quiver, if you will, as part of their business continuity preparedness. So there was a workbook or a plan template that was provided to them by the local health department. They held training sessions on site that were run by local health departments. So under Missouri law, you have to, so Missouri is sort of a bifurcated system that I haven't really addressed yet. You either have to be licensed to dispense medicine, or you have to go to a 3.5-hour training course that is all about pod management and dispensing, and then you can get on a list called the Show Me Response Registry to become a licensed dispenser or to become, a dispenser under Missouri law. So I haven't seen any other communities that do it that way, but that's the way that Missouri does it. So you either have to be licensed or you have to go to this course, and then you can become certified. And so they actually have over 50 people who are now dispensers under Missouri law. Now they won't need 50 dispensers, but they wanted to have a lot of people. They wanted to have backups to the backups, basically, and make sure they had enough people that understood closed pods and could be dispensers if they needed to be called upon to do that. And then they actually organized an exercise. The first one was done in conjunction with St. Louis County Department of Health, but since then they've actually run their own exercises where the health department basically just watches and observes and gives them critiques on what they could maybe do better, but they're very independent as a program and they operate unto themselves. So I think that's a great example where a company just took it and had the energy to run with it themselves, had great management support for it, and I think that's critical if you're going to make it a big program in your company. So I thought that was very successful. So the next case study is actually a national employer, and I'm sure there's some on here that have locations in many states, maybe in all states. So there are a couple that I am aware of. One is a national grocery chain, the other an insurance company, and again, I won't talk specifics. But one has just recently, in the last month, signed an agreement with the state of Texas, and that's a grocery chain. So they're covering over 200 locations in the state of Texas, and last count it was going to be, I think, about 30 to 35,000 employees that were going to be covered by this program. And that was with the whole state of Texas. So, I think that's a good example where, if one thing, and I had said Walgreens earlier, that the CDC is actually working with Walgreens to try and get a national agreement. But the gentleman from Walgreens was at the last Disaster Recovery Journal conference, and he actually said, it's tough because basically we're trying to negotiate MOUs with 3,000 different health departments all around the country, and that's not optimal, and there's no way that could really happen. So that's a real big issue for any national company. One way this grocery chain dealt with that is by dealing with just the state of Texas. They now have stores covered in about 100 different counties, and it's all with a single MOU, a single agreement. And so that really worked well for them. So that's something we're going to be exploring further as time goes on. So the other one is Company 2, that is an insurance company, and they actually have identified, they're just rolling it out to all of their locations. They're doing individualized MOUs with each community. They don't have, they're not in every county in a state, which, thank goodness. So it's a limited number of locations, but it might be a dozen or more locations that they're starting with, and then they'll continue rolling it out to additional ones as they can. and that includes planning, training, and exercising all their plans. And they're actually the driving force behind that, and that's working really well for them. So next, so this is where we get some of the specific questions that were asked before, where we talk about them a little bit. So as a local employer, so I've dealt with this in two phases. So one, if you're a local employer or have a limited number of jurisdictions that you're involved with, then you want to contact your jurisdiction's public health emergency preparedness manager. And generally it's emergency preparedness manager. The other acronyms that are used, SNS planner, so strategic national stockpile planner. Sometimes it's called a CRI planner, and that's Cities Readiness Initiative. If you're part of a large metropolitan area, even a medium to large metropolitan area, you might have a CRI planner, because the larger metropolitan areas get a little extra funding to assist with some of this extra emergency preparedness planning. But generally speaking, every community is going to have a public health emergency preparedness manager. So that's probably where you want to try and start. And you certainly want to receive approval from your management, and make sure that your management is in support of something like this before you would go ahead and contact the emergency preparedness manager. They'll all have their own different requirements. So for example, King County actually doesn't have an MOU. They just have a 4 or 5 page document that they ask you to complete, and then you are a closed pod partner with them. So it's a little simpler in King County. Other communities, most communities do have either an MOU or an MOA, so Memorandum of Understanding. Sometimes they have a letter of intent. It's really each community will do it a little differently, and they'll tell you their requirements for it. Size requirements for a pod vary greatly. Generally speaking, in larger communities, it's more. In smaller communities, it's less. And I'm sorry, I can't be more specific than that. There's also the requirements for dispensing the medication, so you want to find out who can dispense medication under what circumstances, and the medical oversight. That was the other thing that was mentioned earlier. So medical oversight is different than dispensing. Medical oversight is the person that is responsible for overseeing the pod itself, and the reason why they have medical oversight in some states is because if you get somebody that comes in with a difficult situation, maybe they're sick already, or they have some difficult questions, then you have somebody there that has the answers with some medical training at least, and maybe a medical license to deal with that person. Other states, though, have said, we're not concerned about that. We want medicine to get into the most hands possible as soon as possible, and therefore we're not going to require medical oversight. So it really just depends state by state. If you are a national employer, then what that means is that you have a number of different locations, probably in multiple states. And so you want to either contact it, I say local health departments, but you may also want to contact the state public health entity to see if there's a possibility to enter into a state agreement rather than have each county enter into agreement. And that really depends on the makeup of your company and how many different communities you're in. There's also one thing that I propose and advocate is a national MOU. So if a company is everywhere, then, like a Walgreens or a Walmart, if they're everywhere, then it makes sense for them to have an MOU that their legal has approved, and basically you're saying to each community, this is something we've approved, you can take this or leave this, but we're, because we're in 2,000 or 3,000 communities, we're not going to deviate from that and sort of leave it as a take it or leave it proposition. I think that's a good way to get around, and I think most communities because you as a company are doing them a favor to accept this responsibility to disseminate medicines on the county's behalf or the city's behalf. So to me, they would be foolish not to accept your offer to do it as long as they were willing to follow your MOU, as long as the MOU is fair and balanced. Okay, so just last night, I don't know why I came up with the pod squad. I'd never called it that before, but the pod planning committee or the pod squad. Some of you may be old enough to remember the mod squad, which was a show back in the 60s. Anyway, you want certainly business continuity, risk management, human resources who are generally involved in employee benefits or employee, taking care of employees. Security or employee safety, if you have someone at the facility or in the company that's involved in that. If you have a health clinic or medical staff, you'd certainly want them involved in this. Legal as well, at least if there's going to be an MOU or several MOUs that need to be reviewed, you'd want them on board and understanding what's going on. And then operations, that's your choice, and every company is going to be different in terms of what that means. And there may be other organizations that you want to include as well, but that's a good list to start with. Who should be, if you're doing planning for a closed pod situation, then these are at least the people you'd want to start with. And lastly, and we're saving a little bit for questions, but at DRJ there's a post-conference workshop. It is a based workshop that's after DRJ. DRJ, if you don't know, is Disaster Recovery Journal, and they do conferences in March and September. And so this is a post-conference workshop. If you all are welcome to attend if you would like. And that was it, except for the questions page.
Okay, wonderful. We do have a few more that have come in. If these last slides, incited any questions for you guys, please send them over to us. Just use the chat feature on your control panel. One quick note, and this is for me actually, Harlan. I like what you said about a standardized MOU for national companies such as a Walgreens or a Walmart. We use that same approach when we go to individual hotels, and on behalf of one of our clients, we use a standardized contract. So as opposed to each hotel coming to us, with their set of terms, conditions, quirky, tweaky stipulations, and it works very much the same way. I really like that idea, and I think that would make it so much more streamlined for some of those larger organizations that might find it more difficult or might think it would be more difficult to get their arms around how to implement something like this in so many locations. So very good thought, good best practice. Okay, this is, the first one is kind of a follow-up to the one about a minimum number of employees, which I feel like you addressed, but Adriana, if you have still a question about that, please send it over to us. This one says, if you don't have the minimum number of employees in your location or in your company, are you just out of luck?
Good question, and a lot of times I mention this, but there's so much, only so much that I can impart. But yeah, great question. If you don't have enough, one of the things that you can do is you can partner with someone. So if you have, if you're a business in a building that has other businesses, you can try and make it a building-wide initiative, or if you have a neighbor that you can partner with, that's fine. If you're part of critical infrastructure, you can certainly just ask if you can be exempted from that requirement. And so yeah, there are definitely ways to deal with that. You can find out who are presently closed pods and see if they'll just get enough medicine to, if there's one that's in your area, maybe they would consent to get enough medicine to give you a share of their medicine. That's probably difficult if you don't already have a good relationship with that other business, but just anything, from the county's perspective, they want to disseminate or distribute as much medicine as possible as quickly as possible. So they're really going to try and find ways that you can comply with all the requirements.
Okay, good suggestions. I have another one here about basically large versus smaller employee bases within maybe a larger multi-locational company. This says, what if we have some locations with large bases but others with really small? How can I get them all covered?
Yeah, so there's a couple different ways to think about that. So one is if they are close, so if you have a facility that's down the street or relatively close, let's say within 15, 20 minutes away, you can cover those with the same agreement, and I think most counties would be fine with that. If they're in separate counties, you could also, and we have some instances of this, like in Dallas, some companies in Dallas are in Dallas County, but also in counties surrounding Dallas. And so what happens then is all of the medicine gets delivered to the Dallas County or to wherever the largest county is. But if you're in the same metro area, then it's possible that you can just get enough medicine to be able to cover all your facilities at one time. Now, if you, let's say you are, you've branched out and you have, multiple states where you have employees, that provides more difficulty because, first of all, you're only going to activate in one community at a time. I mean, this does not assume that there's going to be multiple anthrax releases across the country that hits everybody like a pandemic does. A pandemic hits every community at roughly the same time, although it starts and stops a little different in each community as it moves through a population. But generally, the pandemic hits all of us at the same time, generally. With anthrax, that's not the case. So it's going to attack a community. It's released in a community at a time, and so trying to cover multiple states in one agreement just doesn't work. Would not work. So one of the things to think about is, so one recognition is maybe you can't cover every employee exactly the same. One of the issues is where are you most at risk, and that may allow you to recognize that you can't cover all employees exactly the same. If there's more risk in a larger facility and less risk in a smaller facility, maybe your risk management equation says, well, it's okay to cover where it's a larger risk and not cover where it's a smaller risk. I have had some companies say, if I can't cover every employee, I'm not going to cover anybody. And to me, that's sort of cutting your nose off to spite your face. I mean, that doesn't make sense. You should cover yourself where you're at greatest risk. And if you have smaller numbers of employees in smaller communities that aren't as advanced and don't have a closed pod program, they're also not as at risk to have an anthrax release. I mean, anthrax releases are going to, if they're going to be targeted, they're going to be targeted, I would think, towards larger larger communities, or not all communities. So that's really, I think every company has to answer that for themselves. But the idea should be to cover as many employees as you can with this program.
Okay, can I just follow up with that? And we only have 2 more questions after this for everybody. And by the way, just a quick reminder, you guys will all receive a link to this because this is very interactive. I know we're getting close to the end of the hour, and I want to make sure that everyone knows that you will get a link to the recording that you yourself and obviously share as you see fit. But with regard to that, Harlan, what if you have small bases that you can't cover? Why should an organization then do it at all? From an HR standpoint, let's say, it seems a little arbitrary and maybe even unfair.
Well, and that's where I think if you did a risk analysis, hopefully the risk analysis of your different facilities would say, it's more likely here, it's less likely here. So if your employee bases are in a smaller community, if some of your employees are in a smaller community, first of all communities are expected to do this. Now, some of them do it better than others, and some of them are slow to respond because of other pressures that they've got. But it is a nationwide program, so it should be in every community. If you talk to your public health emergency preparedness manager in your community, they should be familiar with pods and closed pods specifically. They all have plans for open pods. Most of them, the overwhelming majority of them, want more closed pods. So I would say I don't think it's arbitrary if you do it on a risk assessment basis. I think that's the way you make a case for, well, we can cover, you know, these 10 facilities, but we can't cover these 2 facilities, or we can cover these 100 facilities, but we can't cover these 13 facilities. To me, it's a risk basis. It's going, if it happens, and we all hope this never happens, by the way. I mean, you know, the best case scenario would be we plan for this and plan for this and plan for this, and it never happens. But if it happens, it's more likely than not going to happen in a larger metropolitan area. I mean, I would just think.
Okay, fair enough. All right, 2 more. These are a little more specific. One of them says, is there a secondary education requirement for pharmacy dispensing, such as college, university, technical school, things like that?
I have not heard of any secondary education requirement, so it really, again, depends on the state rules with regard to who can dispense during this type of an emergency. I think the preference would be to have, so pharmacy students, I assume is what this is referring to, and along with nursing students. So nursing students and pharmacy students make great members or volunteers for the Medical Reserve Corps. And if you haven't heard of that term, it sounds like it's asking for medical people, but it's not. It's asking for anyone that wants to volunteer to help during a medical type emergency, but they need at least as many non-medical people as they do medical people. So I would say pharmacy students and nursing students would be great MRC members, and MRC people would be called upon during this type of emergency. So that's one way to get involved. But the fact that they have a little more education is helpful, but if they do not have their licensure, that may not help in states that require licensure. And I think that was an answer to the question. Michelle, do you think that answered the question?
I do, but it came from Joseph, and Joseph, if you don't think that answered the question, please let us know. You've got a little bit of time because we have this one more. This one says, in the event of a radiation release, either accidental or intentional, do potassium iodide pills provide any type of protection at all?
That's a great question, but I'm not a medical professional, so I'm not going to answer that question. I'm going to defer that question.
Okay.
That they do, but you're talking about, I mean, I'm just a layperson in that regard, so I can't give an official answer.
Okay, that's fair. And I'm a little embarrassed about this, but I need to ask you, did I mispronounce your name early on? Is it Dolgin or Dolgin?
It's actually Dolgin, but you were certainly close enough.
Well, I was close, but I don't want to butcher it at the end here, so I do want to thank you very much for sharing your expertise with us today. Just to let everybody know, we are in the process of scheduling the next several webinars that are part of the ACP webinar series, and by attending today, you're going to receive information about those future sessions and where you can register. I'd like to thank each of you for attending and ask that you please take the 30 to 42 seconds to complete the survey that will pop up in just a moment. Doing that really does help us provide you with more productive and instructive webinars. Please let us know also if Continuity Housing can help you by providing housing for your critical personnel when you need it during a deployment. For Harlan Dolgin, SOFT-G, the Biodefense Network, the Association of Contingency Planners, and Continuity Housing, I'm Michelle Lowther. Thanks everyone again for joining us today. Hope you have a great week.